meeting of Human Services to order. First thing on the agenda is the approval of the agenda. If I could have a motion to approve it.
So moved.
Support. Second. All in favor?
Aye.
Aye.
Okay. Public comments. Comments? Then we'll go down to the minutes. Can I get a motion for approval of the minutes of January 7th? Do I hear a second?
Second.
Favor?
Aye.
Aye. Opposed? Okay, appointments.
I'm sorry. Just a.
Sorry, may I continue? Next on the agenda is appointments for the Veteran Affairs Committee. New term expires on March 2020. Current member is Virginia Maitland, and the applicant is Richard Arnold. Any comments? Commissioner comments? Anybody could have a motion, please, to accept?
We accept Richard Arnold.
Support.
All in favor?
Aye.
Opposed? Welcome, Mr. Arnold. Lifeways monthly report.
Good afternoon. I'm Shannon Clevenger from Lifeways. I'm here to give you just an overview of the packet that you received. Just to let you know, the millage dollars began in January of 2019, so we've started seeing people under the millage funds that Lifeways has been allocated. Mary Beth will be bringing a quarterly report here, so that first report will come in April to let you know how many people we've served using those millage funds, costs and types of services that they're accessing. Mental Health Summit, we'd like to invite you all to attend the Mental Health Summit in 2019. The summit's open to the public. Topics that we're going to be covering: gun violence, mental health in the Black church, veterans, substance abuse, stigma, domestic violence, and LGBTQ. The event's at Baker College. There's a link in your electronic document where you can register right there. It'll be all day from 8 to 3. An update regarding Healthy Michigan. The federal government CMS department has approved the Healthy Michigan waiver for the state of Michigan. This will support our Healthy Michigan plan, which is our Medicaid expansion for another 5 years. This waiver included the additional work requirements, but we did see something over the weekend. The new governor might be making some adjustments to that bill as it was presented previously, and so we're waiting to see what those work requirements may change into. The state law currently stipulates if the federal government rejects the waiver request or it's determined to be non-compliant, the whole program will go away. But because CMS approved it, we're hoping if there are some changes that are done to the current legislation in the state of Michigan, that won't impact the waiver. The MyPAD update, which is the Michigan Inpatient Psychiatric Admission Discussion Group at the state. MDHHS, the Michigan Department of Health and Human Services, has worked with the Certificate of Need Commission to convene a work group to review the methodology for psychiatric beds and services in the state of Michigan. They published a new policy bulletin to require Medicaid providers to accept, honor, and use the standard consent form for sharing behavioral health information for care coordination purposes. The department has also been working with the Michigan legislature to pass legislation, this is House Bill 5439, to authorize the development of a psychiatric bed registry, which should hopefully help reduce the number of individuals who are boarded in EDs waiting for beds. If there's a central bed registry and we have a person who's in need of psychiatric inpatient services, we would be able to access a central bed registry, look for a population type, and be able to know where the beds are available in the state of Michigan. And that's my update.
Thank you very much.
Yep.
Any questions, commissioners? Oh, I need a motion to accept this.
Thank you.
Favor? Aye. All object? Any objections? None. Okay.
Thank you.
Thank you very much.
Good afternoon. Marcy Wandell with the Department on Aging. And with the cold weather we've had recently, just wanted to make sure you're aware that our Meals on Wheels participants do receive what we call emergency meals late in October, early November, in preparation for days when we can't deliver meals due to weather. And when it's an extended period, we also call what we call our Priority 1 participants, people who may not have contact much with neighbors or family or friends, just to see how they're doing. Do they have heat? Do they need anything? Do they have enough food? So that process did take place when we had those 3 days of below zero wind chill. And the Friends of Jackson Seniors is a nonprofit organization that the Department on Aging partners with, and the first Thursday of March is an event called Soups On for Seniors, and this is to raise money for the Meals on Wheels program. So the donations go to Friends of Jackson Seniors, and then after the event, there are business donations as well as through the event. Then the Friends of Jackson Seniors donate money, all money raised. They cover expenses, the Friends of Jackson Seniors do, so all money that's received comes to the Jackson County Department on Aging, and we've been using it to replace one of our meal delivery vans. And the amount they donated last year is listed at the bottom of my report under the 2018 community donations. So there's information about the event, and can go online to purchase tickets or give us a call. It's March 7th at Ella Sharp Museum, 5:30 to 7:30 in the evening. And our grant funding is governed by grant standards that the state of Michigan develops. And they recently updated the nutrition standards, and it's made it more broad for us to be able to provide more meals in more opportunities for older adults to receive nutritious meals than what we've previously been able to offer, and we can count them as grant-funded meals. For every meal, we receive grant reimbursement, but also a USDA per meal reimbursement. So now we're starting a couple pilot projects. One is for exercise class participants at Spring Arbor Senior Center. They're done with exercise class at 10:30. They're not interested in waiting until noon for a hot meal, so now they'll be able to take a nutritious cold meal home with them so that they do have that good nutrition, healthy nutrition, which is an important part of having, keeping our bodies well and staving off disease. All the exercise and the nutrition are important components for that. So it'll be the same donation, suggested donation as the hot meals. And then at Park Forest, which is a subsidized older adult apartments, many participants they're not homebound, so they don't receive Meals on Wheels, but it would be helpful for them to have meals on the weekend. So we have started offering frozen meals for them to take with them when they go to the nutrition site on Friday. Then they take frozen meals into their apartment to heat up for the weekend. So those are two new things that we're kind of piloting to see how those go. Any questions about anything? Okay.
Thank you, Marcy.
All right, thank you.
Okay, next on the agenda is sexually transmitted infection presentation. by the Health Department.
Can be a bit of a tongue twister. Good afternoon, all. So what we have worked hard over the past, 3 or 4 months, if you will, was to pull together information on sexually transmitted infections in Jackson County, and making a distinction between the city and the larger Jackson County area. And we've done that. It has taken us perhaps longer than what we would like it to take, but we're subject to getting the data in a form that we can work with from the state of Michigan. So it sometimes can take a while. So we have been able to characterize it by age, gender, race, and ethnicity in the community. A little background, Commissioner Mahoney specifically requested that we provide some information on this, so that's partly what's behind it. And a few definitions. Incidence is the number of new cases of a disease or condition over a specific period of time. It's usually expressed as a rate per 100,000. So that is our standardization, if you will, for looking at this data that we're about to present to you. So looking at this from the perspective of overall chlamydia and gonorrhea, these are the two STIs of most concern in our community. The average annual number of new cases is displayed in this chart here. You'll see that the time frame is December 1st of 2015 through August 31, 2018. That's just the span of time for which we have the data collected, but really what we're presenting to you is kind of an average 12 months, so from within that time frame. So the blue represents Jackson County without the city, and in Jackson City itself, you can see what the numbers are for both of these. And it should be pretty clear on what the disparity is here in terms of the number of new STIs. 83% of them are occurring among city residents. And they are, what, perhaps 25% of our population or so? And then we'll look specifically more at chlamydia, and then we'll look at the gonorrhea side of it. Chlamydia incidence rate. Chlamydia is a bacterial disease, if you will, transmitted sexually. So is gonorrhea, but they're different organisms. So we're talking about a bacterially caused disease here, sexually transmitted. In the county overall, these are the incidence rates now per 100,000. 547 overall in the county, 2,150 in the city. And that's kind of reflective of the previous slide in terms of the number of cases. But when you calculate this out based on per 100,000 persons, you can see what it is. And in Jackson County, the number is really quite significantly smaller, 122 per 100,000. So again, most of our STI transmission or new cases that we're seeing are coming from within residents in the city. And city residents are 17 times more likely to be diagnosed with chlamydia versus county residents outside the city. So we have a huge disparity. Yes, which includes the city. Right. Well, right, that's a rate per 100,000 because it's based on population. Okay?
Is the first number also a rate?
Yeah. The first number, the 547, is also a rate per 100,000 persons. No, because the county population is a lot larger than the city. Yeah. Yep. Okay? No problem. And new cases by age, we've broken this out by age as well. You can see here that primarily it's people 20 to 29 years of age who are becoming infected with chlamydia, not exclusively, but predominantly. And most cases are occurring among adolescents and adults up to age 29. The split in chlamydia and gonorrhea cases by age in the county, including the city, there really is no significant difference in terms of differences among people who are aged the same in the county and the city. It doesn't make any difference. It's the same age group. This is chlamydia cases by age in Jackson County without the city.
Richard,
Yes.
is the presentation
Should be.
No, it isn't.
It's
right
not?
from the beginning.
It's not.
Different
Uh-oh.
color.
Different.
Oh, sorry. Okay, well, let me see if I can find the correct one. I'm glad somebody said something to me. So, let's see here.
Started off the same.
Yeah,
To be at different colors on the graphs.
Colors are different.
yeah. Okay, I think. Let's hope this one's right. Yeah, I think this one's right. Okay, it had a little bit more introduction as well. Chlamydia is a common STD that can affect both men and women. The initial damage that chlamydia causes often goes unnoticed. Sometimes we wonder, why is this important? However, chlamydia can lead to serious health problems. It can cause serious permanent damage to a woman's reproductive system. This can make it difficult or impossible for her to get pregnant later on. And untreated may also increase the chances of getting or giving HIV. There is a relationship between different STIs, if you will, in terms of one kind of being synergistic with the other. In men, it is rare to have a problem in males with chlamydia, although it can sometimes cause problems in their reproductive system as well. It's primarily an issue of concern for women. So this slide actually is one that wasn't in what I was already talking about. State of Michigan, 512 per 100,000, and in Jackson County, slightly higher at 547, so we're a little higher than the state. This is the same slide we were just talking about a minute ago, updated with better colors for you. Overall chlamydia, an average annual number of new cases. Again, you've seen this one. 82% of new chlamydia infections occurred among city residents. I think that's an update from what I previously talked about, so it was a little bit higher than what I had showed you. 54% of newly diagnosed chlamydia cases were among 20 to 29-year-olds, and 81% occurred among this age group living in the city. In terms of percent of cases, if you will, where they're occurring within the gender population in the community, females in Jackson County are nearly 2.5 times more likely to be diagnosed with chlamydia than males. Part of the reason for that is males oftentimes don't recognize any signs and symptoms associated with chlamydia infections. That's not the case for gonorrhea. The percent of chlamydia cases by gender, again, this is looking at the same numbers, but on a percentage basis between the county without the city and the city itself. So the distribution of cases is similar for males and females. It doesn't really matter where you live. The number of cases by race and ethnicity, we have African Americans represent just 8% of the Jackson County population. They are disproportionately diagnosed with 26% of new cases of chlamydia. So this is definitely a disparity in terms of infection with chlamydia, and underscores why we perhaps have done as much work as we have at this point in time within the city trying to address this issue. This one's a little bit more complicated. This is looking at cases by race, ethnicity, and gender for chlamydia. The bottom line takeaway here is overall 71% of all new cases occurred in females, and 31% of new cases occurred in white females living in the city. Just to give you some sense that this isn't an only single race issue in the community. Now we're going to switch over to gonorrhea, a sexually transmitted disease that can affect both men and women. Often no symptoms associated with the infection, which can lead to a lack of diagnosis and treatment. It can cause serious and permanent health problems, including pelvic inflammatory disease in women and infertility in both men and women. And untreated may also increase the chances of getting or giving HIV. The incidence rate for this is a lot less than it is for chlamydia in our community and in the state. Interesting that the state of Michigan is quite a bit higher than we are, 1.8 times. and we only had 80 within an average 12-month time frame. The average incidence rate of gonorrhea, you can see what it is for the county overall, which does include the city. City residents are 28 times more likely to be diagnosed with gonorrhea versus county residents at 337 per 100,000. And then when you separate out the city from the county, just 12 cases per 100,000 out in the county, just without the city included. So we know where the focal point of our efforts should be. The average number of new cases, this is showing kind of just the split between the city and the county, 15 in Jackson County, 113 in the city among city residents. The average number of new cases by age, this is a breakdown that shows it's very similar in a lot of respects to chlamydia. So one could argue that the same people who are becoming infected with chlamydia are in the same age group as those contracting gonorrhea. So again, 52% of new cases were in the 20 to 29-year-old age group. Cases by gender, again, distribution of the cases is similar for males and females. This is regardless of residential location. The cases by race and ethnicity, you can see that the African Americans again represent just 8% of our population, but disproportionately were diagnosed with 40% of new gonorrhea cases. So, we continue to focus a lot on what we can do within the city of Jackson to help bring the rate down. This is the complicated slide, race and ethnicity and gender and geographical location. 45% of new cases are occurring in black males and white females living in the city. That's kind of a combination between the two. So you can see that the black male number is quite high here, and this is the white female number here. So from a conclusion standpoint, our overall incidence for chlamydia increased by 8% from 15 to 17 and is 5% higher than the state of Michigan. The rate for gonorrhea increased 117% from 15 to 17, but remains 46% less than the state of Michigan. Residents living within the city limits are 17 times more likely to be diagnosed with chlamydia and 28 times more likely to be diagnosed with gonorrhea than residents living elsewhere in the county. 54% of the cases and 52% of gonorrhea cases occurred, again, in the same age group. The next largest age group is 10 to 19-year-olds, making up 33% of new chlamydia cases and 23% of gonorrhea. Females are 2.5 times more likely to be diagnosed with chlamydia than males. And overall, white males and females are equally likely to be diagnosed with gonorrhea in Jackson County. African Americans in the county were disproportionately diagnosed with 26% of new chlamydia cases and 40% of new gonorrhea cases in Jackson County, and that includes the city. Within the city, 50% were diagnosed among black males and white females. So I want to talk a little bit about what resources do we have in place in the community that we're trying to bring to bear on it. Well, we've had the STD clinic in Jackson County for many, many years, probably 25 to 30 years. The clinic fee is $11 for in-county residents, $41 for out-of-county residents. No client is turned away for inability to pay, and we don't get many out-of-county residents coming to our STD clinic, but we do get a few. The screenings that we're offering include gonorrhea, chlamydia, syphilis, hep C, HIV, trichomonas, genital warts, yeast infection, and pregnancy. We have a strong emphasis on condom use and free condoms available. Outreach activities including strong condom distribution through various organizations in the community that we work with. And we recently name changed the clinic from STD to Sexual Health Clinic because it's less stigmatizing. Treatment is provided at no cost to client for gonorrhea, chlamydia, trichomonas, warts, vaginosis, and yeast. We do receive medications from the state of Michigan through the STD program for that purpose, so it doesn't really cost us too much out of pocket. Presumptive treatment is provided for probable cases to decrease the barrier of return visit for medication retrieval. We also do expedited partner therapy, which is offered for chlamydia and gonorrhea to ensure partners' treatment even if the partner cannot come to the clinic. So we're basically using the case that's sitting in front of us to hopefully distribute meds or a prescription, if you will, that can be obtained through the pharmacy for the partner. It's difficult sometimes to be successful with partner contact tracing and to get them actually into the clinic to be seen. Extragenital screening is offered for at-risk men who have sex with men to ensure rectal or pharyngeal cases of gonorrhea are not missed in the traditional screening process. We could do a bit more with more resources. We really would like to increase authentic engagement with clients in the sexual health clinic to explore future strategies, which would result in an increase in screening and treatment and to decrease the spread of STDs. So that means actually finding a way, if possible, to sit down with the people who are coming to the clinic and maybe kind of a focus group setting and asking them, what else could we do to help you not get infected with an STD? Another option, which we've explored a little bit as far as looking at the information, is to consider establishing a community advisory board to develop strategies based on community partner engagement and to evaluate interventions for reducing rates in the community. We don't have a group of people from multiple organizations or agencies in the community who are also doing the kind of work that we're doing, coming around the table, sitting down with us and meeting and talking about what else we could do. Expanding partner services and partner follow-up for nursing staff to follow up with partners and clients who've been exposed to gonorrhea or chlamydia when partner information is provided. There is an increase in reported sexual encounters originating from dating websites, which often result in little-known partner contact information. People may not even know who the person is that they're hooking up with, sadly as it is, and don't even necessarily exchange much information, including names. So we're kind of wondering if providing advertising or messaging about testing and treatment on commonly used dating websites might be an effective way to go, but for what we're hearing, it's costly. We're aware of a pilot project that the state of Michigan engaged in where they actually identified a number of social media sites where supposedly these kinds of contacts occur, and one of them charged about $33,000 to post up prevention-related ads, if you will, for a relatively short period of time. That's not within our budget. Offering bus tickets to at-need clients for return visits for follow-up, that would be something we'd like to be able to do if we had the resources to do it. So we're going to continue to seek resources that can be used to address the disparities that we identified in the different population groups in the county and try to prevent further transmission. It's what we do on a daily basis. So happy to take any questions that anyone may have about any of the content in the presentation.
I just wanted to say thank you for putting this information together. Just a thank you to you and the staff for putting this information together. It's very useful.
You're welcome, and if we can connect up in some way with more people in the community that are part of your district as well, we'd like to do that. They might be a bit more at risk than some other folks within the county. So feel free to reach out to us for that.
Mr. Chair, I just had one question. Is this information on your website at all? Is this accessible to the community in any way? Can it be, if not?
It can be. This whole presentation can be posted up. We're happy to do that. I don't think it is right now, but we can do that.
Okay, thank you.
And also, we do post up a quarterly communicable disease report on the health department website as well. And that's accessible, and it kind of gives a snapshot of new cases of communicable disease diagnosed within the last quarter. So that's there as well.
Okay, thank you.
One question, do you have any kind of campaign where you go to doctors' offices and give them material
Yes.
or a sign to put up? And is there a campaign out there to educate the people about what you offer and what these two diseases are so they understand it? Because I bet you there's a a lot of people out there who never heard of it.
Yeah, we do have a routine number of other healthcare providers' practices and offices that we go to and make sure that our brochures and contact information and clinic hours and things are available in their office, so we do that. Do we have as well of an organized campaign for reaching out and sharing information as what you're describing? Probably not. Probably wish we did and had the people time to do that. But we're doing the best we can with what we have.
Thank you, Richard. Very good report.
You're welcome.
I have a question. If you're going to put this report on your websites where people can access it, I attempted to print it off, and what was on there doesn't print easily. The text is too wide, it goes off the sheet.
Okay.
It's very short, there's too much at the bottom, that's just wasted paper.
Yeah,
So the format of the PowerPoint isn't a good format if you wanted to print this off and distribute it.
Okay.
So if that information could be manipulated, so it's,
Is that the PDF version that you printed from the board docs?
yes,
Yes, it's just the landscape, yeah.
Okay, okay.
So if you, there's a way to print it where it's a little more concise under your options.
yeah, if I'd put it landscape, it would have been better, but still, if you're going to print it out,
Under your computer settings, there's a way to print it out where it shifts it, where everything is all centered.
okay,
So,
you have to show me how to do that.
Will
I
do.
wasn't able to.
I appreciate your input for us. Thank you. Yep. So we bring to you this afternoon a third amendment to the Laboratory Director Services Agreement that we have with Henry Ford Legion's Health. It's been a successful arrangement at this point in time, and so this would be the third year that we're doing it. We do have to have a laboratory director designated for the health department, particularly in support of the STD clinic. So we've agreed to renew that agreement for an additional year with Henry Ford Legion's Health. There's no increase in cost for this particular agreement, and the estimated total cost of it is right around $3,000 a year. So it's pretty cost effective for us and has worked well. So we would seek your approval to continue the agreement for another year. Thank you. Yeah, so I wanted to take a minute and give a little background for this particular item. Drug Free Jackson is our substance abuse prevention coalition here in Jackson County and receive funds from the state to support that. Commissioner Tompkins had asked us to come and bring some information, if you will, about harm reduction and harm reduction services that might be of value to Jackson County and overall. And so what I did was I reached out to the coordinator of Drug Free Jackson, who has been very close on this issue and has done a lot of background work with it with the community group that's working on it, known as Jackson Harm Reduction. Sarah Allison is the coordinator and health action team coordinator for Henry Ford Legion's Health, as well as Drug Free Jackson. I've asked her to come up and make this presentation to you this afternoon.
Hello. A little taller than Richard. So, like Richard said, I'm Sarah Allison. I did want to put a disclaimer that anything I say does not reflect the hospital's views at all. They're just our fiduciary for Drug Free Jackson. So, It does reflect Drug-Free Jackson's views on it as well, and I just wanted to go through, there we go. Just an intro between the two groups that have come up, kind of where we're at right now, and then what harm reduction does to help that. If I take too long, just let me know and I'll wrap up. Drug-Free Jackson currently works on a continuum of drug use. So we work with prevention, which is like stopping kids from actually starting to use. That's primarily where our focus is as a coalition. We also have members who do intervention, if you've heard of Breakout Drug Education. They're on the prevention side, but Family Services and Children's Aid also does JUMP, which is Just Understand My Potential, which is first-time offenders who in intervention works with people who have kids or people who have indicated that they either are using or are at high risk for using. And then treatment and recovery. And when I talk about recovery, it's not using anymore, but there's always still a risk of relapsing. Jackson harm reduction itself is on the intervention part. So it would be people who are using and how can we get them into treatment and recovery. They are not currently in treatment or recovery that we would know of, but it would be connecting them with those resources. So just to differentiate between the two groups, sometimes things get really confusing. So where we are right now, you can see IDU is intravenous drug use or injectable drug use, depending on who's using the acronym. It rose 93% in a 10-year period. That's astronomical. Currently, we have about 115 deaths daily. So by the time I will be done with this presentation, 1 or 2 people will have already died nationally from this crisis. And between 1999 and 2016, there was 300% spike in overdoses, drug overdoses. So not just heroin, but also cocaine, meth, that kind of stuff. And that's not deaths, that's just people who have overdosed. You can see in this picture just the overdoses and how, I mean, really every single drug that you can inject has drastically increased. Specifically synthetic opioids, so you've heard of fentanyl, that fits in that category.
Why do you think that is?
The spike, I have my theories, but I think it's, well, and I'll get to it a little bit later, but the way that we regulate things now isn't working. I think a lot of people are hopeless too, and can turn to things that maybe are harmful to help with that. I mean, with drug use in general, you're either using it to feel good, to fit in, or because you are using it as a coping mechanism. So with all of these, I mean, you could say that that would be the case. Yeah, fentanyl itself is 100 times more potent than morphine. And carfentanil, which is like a big animal tranquilizer, is 10,000 times more. So even getting 1 grain of carfentanil in your heroin or your methamphetamine, they all look the same. They're all white powders. You know, it's a very risky business. So that definitely has led to an increase. I know China is putting regulations on fentanyl production, but it comes through the mail, so who knows, you know. Hospital admissions for opioid, they have increased 58% over the last decade. Hep C tripled in the last 5 years. HIV increased 4%. I know in Jackson, most of the HIV cases are from men having sex with men and not necessarily intravenous drug use. This is just a chart from the National Survey on Drug Use and Health. You can view it at your own. I highlighted a couple things, which you can't really see on the slide, but cocaine, crack, heroin, methamphetamine, we just have, as a nation, just high uses, and we don't talk about crack a lot or cocaine a lot, and it's higher than heroin use. So there's theories behind why that is too. And we just have to be aware that it's not just the heroin and the opioid problem. Here we go. Now I highlighted it. As far as Michigan itself, Hep C rates have increased 473% in an 11-year period. 94% of Hep C positive young adults reported using needles. That's huge. That's probably where they're getting it. It's not through sexually transmitted. 13.3% increase in drug overdose deaths in 1 year. And then Michigan is in the top 15, or top 19 states that had statistically significant increases in drug overdoses. If you look at the map, Jackson has over 28.1%. Sorry, the rate is 28.1%.
28.1%.
Thank you, it's not percent. It's 28.1 per 100,000. But it's high, and if you notice, like, the rest of them.
I have a question.
Yeah.
Do we count anyone that's incarcerated in our prison system
No.
and in this at all?
They're not.
Thank you.
Residents. But if you, well, they are, but in the state system, they don't count them. I think it'd be an amazing study to see how that fits in, though, especially with the prison being here.
Hopefully in prison, they're not.
Hopefully.
I mean, come on.
There's articles, you can find them. I know. The other thing I wanted to point it out with the map is that if you notice, all the other counties that are high are rural areas. Jackson does have a rural area, but we do have a pretty heavy urban center.
Sarah,
Yeah.
what hepatitis C?
It can lead to, well, Richard, you probably can answer that better than I can because I don't have that background in STDs. But, like liver inflammation, cirrhosis, that kind of stuff, disease. Mm-hmm. Sure.
Hepatitis C. Bleeding, death.
Very latent.
Correct.
I assume you know, you got the right letters at the front of your name. In Jackson, hepatitis C rates have increased for all age groups. So this chart just shows in the blue, people over age 31 have seen huge spikes. And then for cases that are under the age of 31, I mean, they're both increasing. We just pointed this out, the difference. I cannot give you the background on why, because I think this is health department data, but additionally, so we don't have any way of asking people in Jackson specifically if they use cocaine anymore or any other drugs. So we do a community assessment every 3 years. The last one that we asked heroin and cocaine use and methamphetamine use was 2014, and 15% had said that they had tried at least once. That doesn't mean they're a current user. But that's still pretty high. And then drug-related deaths increased 23% between 2014 and 16. And this is medical examiner data that is in our 2017 drug-related overdoses data report, whatever we called it. It's on the county health department website. You can get a hold of it or contact me and I can send it to you. But if you look in 2017, cocaine and heroin deaths were the same, but we had so many more with fentanyl in them. So obviously the fentanyl is, at least as of 2017, is very high. We don't have the final results for 2018 yet. There is a 2018 report, but it doesn't have all of them because toxicology takes up to 3 months and we don't have all of December's numbers yet. I do know that deaths have gone down since 2017. 2017 was our highest. So this maybe, Michael, just to get to your question a little bit on why. This is a quote from the drug czar under President H.W. Bush, and I think it really speaks to how a lot of policies are made around drug use. We work too hard with law enforcement to get people into prison, and we're not going to do anything different. And that's what we hear often. This is in reference to the spread of AIDS, but you could throw in Hep C, you could throw in, the medical diseases that come with using that kind of stuff, HIV for sure. Right now, so as the state of things, we see drug use in 3 different ways. It's a moral failing. You did this to yourself and you deserve these consequences. I know some of you guys may have grown up with the Just Say No, Nancy Reagan and DARE. It's on you as an individual to make those decisions and to do what's right. Never mind your environment, your family, your genetics. I grew up with DARE, and there's plenty of evidence to say that neither of these 2 campaigns worked. And then we have a war on drugs and criminalization, so we have an entirely full jail and prison system that is putting people in prison without any, we have treatment court in Jackson, and that is a good thing, but you have to meet special qualifications to get there. We know that these 3 items don't work. They have probably never worked other than making people feel horrible, putting them in jail, and taxing our systems. So yeah.
Stress.
Mm-hmm. Exactly. Yeah, and I will actually talk about that, so, yes, thank you.
I don't think you can base judgment on whether these worked or didn't work, because everyone that it worked on isn't in the system. You don't know the people that have not used, like myself, that have not chosen to use heroin, that have not chosen to use intravenous drug use or use crack or any of that stuff, that this stuff didn't work on me as a prevention when I was younger. I don't think you can use that as a blatant statement that it didn't work. I find that hard to believe when I look at the high school athletic programs and everything else that reached out to these kids to keep them from using.
So athletics for sure is a good incentive. If you don't use, you can't. If you use, you can't be on the team, and most kids want to fit in. There's several studies though that have looked at DARE and the before and after, and have found that there's more use especially with at-risk teens, after they completed their DARE program. And a lot of it is just outdated methods of prevention. So now we educate, we encourage, but we don't bring in people with personal stories because they're successful, right? So we have people in recovery in Jackson who are successful, they have family, they have jobs, and when you have a youth that is using in school, they see that as, well, it's gonna work out okay for me. So it's, yes, and for me it worked. You could yell at me, you could look at me sternly, and I'm done. Like, I will never use again. Tell me you're disappointed, but for a lot of kids it didn't work for them. So kind of the direction that prevention and drug work is going in are these 3 things. So we now know it's a disease, not just it's not a moral failing. There's actual brain scans that you can look at that people who use drugs and their dopamine receptors are destroyed. So they have to keep using to feel good. We also know that medication helps. With people who are using drugs. We use education and systems change. So Dr. Tompkins, like you were saying, getting the system to change so that those things, the stressors are lessened. And then harm reduction and recovery. So getting people into a harm reduction center, then to treatment, and then to recovery ultimately. I'm not going to read this, you've got it. Basically, harm reduction just meets people where they're at. So instead of saying you need to be here in order to do anything, it says, okay, you're here, and let's get you there in the way that you can get there. And it's different for everybody. Our partners at Home and New Vision frequently stress multiple paths to recovery. AA might work for somebody, but for somebody who doesn't believe in a higher power, this might work, that kind of stuff. It's non-judgmental. It doesn't use coercion to get people to where they need to be. So if you want this job, you have to be here. It's let's work with you to get here. And then back to Dr. Tompkins, what you were saying, the social determinants of health. So the environment around you, what does the city look like? We know that First and Franklin is a really rough area for drug use. Are there kids living there, and is that what they see? There's some other things on here. Education, we know there's tons. If you just go to youth.gov, there's a list of risk factors for every age group of youth from I think it's from 25 and under, at their milestone, so like early birth to young child, to middle school, to high school, to young adult, that shows that all of these things in place can really lead a person to using, and it's not just their behavior. So an SSP is a syringe service program. They can encompass a lot of things. We don't necessarily want to do all of these things. I know that there's, people get on edge when you hear about safe use places, and that's not necessarily what we want to do. We just want to provide people with clean services, clean needles, cotton, that kind of stuff, so that they don't transmit the diseases that they have. Condoms, that kind of stuff. Eventually get them to medication, and obviously eventually getting them to a place where they're not using anymore. So I have a couple case studies, if I still have time, of how this has played out in different communities and how it worked. So in Scott County, Indiana, this was in 2015, the county size is about 24,000 people, so it's similar to Summit Township. And their main city, Austin City, is about 4,200 people, and that's maybe roughly the size of Vandercook Lake. So they had 142 cases pop up due to HIV due to illegal drugs. And it was from a pill called Opana that they had crushed up, and because it was a really sticky pill to mix up, like literally sticky, they had to use a higher gauge needle, which causes more of an impact in your skin. And then naturally they spread it because they shared needles. It's pretty gross. This image just shows the higher, let me get this right. The blues are people who are uninfected. As you can see, they're very small, like the actual size of the dot is small. The red are people who had HIV positive, and the size is according to the number of high-risk contacts reported. So this spread very quickly is all that shows. Of the 117 individuals who reported over 3 times using an injected drug and having over 3 partners who also used, 93.2% were infected with HIV. So basically all of them who had shared were infected with HIV. 48.7% of the individuals with more than 3 injection drug using partners and at least one so somebody that they had sex with and shared a needle with, they had HIV infection by the end of this. And then 87.1% of individuals who reported 2 to 3 injection drug using partners, so they've shared with 2 or 3 people, and at least 1 sex and drug using partner had HIV. Basically, there were multiple pathways to getting HIV. They all included injecting drugs. So they ran a couple models on this after. Basically, what Scott County did was they put in a syringe exchange program, and they allowed people to come in at will and do like an equivalent exchange. So bring in your dirty needle, we'll give you another a clean needle, and then encourage them not to share with each other, and that like drastically like almost eliminated the number of incidences in just doing that. So somebody ran a model to see how this could impact if they had done this sooner. And if they had started this, so the cases started popping up in 2011. If they had started it in 2011, they would have reduced the number of cases to less than 10 over the 142, sorry. And it would have saved, and if they had done it in January of 2013, it would have been less than 56 cases. An estimated $120 million in HIV treatment could have been saved. And then Clark County, which is the next county over from Scott County, could have had a 30% reduction in overdose deaths between 2016 and 17. So that was with HIV, which, like I said, most of the cases in Jackson now for HIV are men having sex with men. But Iowa more recently did a harm reduction center, and they, in patients younger than 40 years of age in 2000, they had 36 confirmed cases of hepatitis C. So that kind of mirrors where we're at here in Jackson. By 2016, there a 1,055% increase to 416 confirmed cases. C. So 75% were from intravenous drug use. Then they, at a state level, they formed the Iowa Harm Reduction Coalition in 2016, and they dropped those cases 16%. And from the Iowa Public Health Department, they were quoted to say, "The only thing we know that's different is underground needle exchange is going on in the state. That's the only variable that we can find after analyzing the data over and over and over." There's a lot more in the literature that speaks to the reduction in communicable disease through harm reduction centers, and that obviously is a tenet for harm reduction, right? We recognize you're still using, but we can reduce the harm that is going to happen to you, even though you are still using and that is still harmful. But we can help kind of mitigate some of these things. So I don't think I need to go through all of these. In this one specifically, they reviewed, it was a meta-analysis of 33 different studies, and they looked at, there's criteria for public health programming. It's called the Bradford Hill criteria, and they looked at these 33 studies to see if they met any of the 8, and almost all of them did. In 24 studies involving over 1,100 people who inject drugs, syringe services were, people who use syringe service programs were less likely to share, lend, reuse, or borrow syringes. And if we know that you transmit diseases through sharing, that's a good sign that they did all of that. This one was interesting. It's a mathematical model that they just, basically the premise is the longer the needle is in circulation to be used, the more likely it is to be contaminated with a communicable disease. And so they looked at how long a needle could be in circulation and how many people it would affect. And if a needle was taken out after first use, how many people would be saved. And they said that 1 to 3 infections, and this was HIV specifically, but 1 to 3 infections could be prevented with this syringe program. I don't think I need to talk about that one. This I thought was interesting. This is from the World Health Organization. It's from a presentation that they did specifically on this topic at one of their summits. And to prevent hepatitis C, if you combine OST at the bottom is opioid substitution therapy, so that could be we call it MAT, medication-assisted therapy, but that could be Suboxone, that could be Vivitrol, that could be methadone. So it's just replacing those, and then a needle syringe program, and if you combine both of them together, which is highly, highly, highly recommended because not one thing is always going to work, you can reduce the odds of acquiring hepatitis C by 80%. And we do have medicated-assisted treatment in Jackson County. It's not available to everybody and is expensive, but they use it in the jails, which is a good place. And then finally, I just wanted to quote, because a lot of, just to look at it from a racial standpoint, it is consistently talked about as the white person's problem. Even in Jackson County, more whites are overdosing at a higher rate than African Americans or Hispanics. But when the CDC they studied 12 cities, and they found that even these needle exchanges can reduce the number of African Americans who contract HIV specifically, but and then same with Latinx. So it does help everybody. And in Michigan, so this isn't a new thing. These have been around since the 80s when the HIV problem started happening, when we started noticing this. Through, men having sex with men, but they've been around for a long time, and they've been super successful. And in Michigan, we have 8 that already exist and that are doing really well. The one that we've worked closely with is the Red Project in Grand Rapids, and they've kind of guided us on a path to take, especially with law enforcement, and then how to get people there, but keep it so it's a lot of word of mouth. We're not going to put a billboard up. but getting people the stuff that they need. Some of these other places, they all have websites. In Jackson, we do have Unified, which works with HIV specifically, and they only give out to their clients. But we need to expand that beyond just their clients, because clearly we have an issue. Are there any questions?
Unfortunate presentation.
Yeah.
But are you saying that all the studies say that the needle exchange program reduces, infection? Mm-hmm. Are there any studies that say otherwise?
There probably are. I didn't look for them.
Well, you should
Yeah, unbiased presentation, right?
do what? That it does, you say? Well, that's what I'm trying to get to is
Francisco and other major.
so the good doctor is saying that vast majority, at least, say it does. Okay.
There was one in here that, it was actually that CDC one. When they did the studies in the cities, that white users actually just plateaued. They didn't increase or decrease in their HIV spreading. They just plateaued, which could be, you could definitely take that as like, you're not doing much, but I don't know. I still stand by what I say. Yeah.
I understood, basically, your presentation is that a needle exchange program is, I assume you're saying it's worth the investment because we save money in the long run through less illness.
Absolutely.
Okay. Is there any studies that show that it prolonged or influenced additional drug use or created new drug users?
Almost all of them have said that it does not.
So,
At least the ones that I looked
have
at.
they studied it, I guess, is the question.
Yeah, that it doesn't increase. In fact, because you're getting people to a point where they are talking to a person who treats them like a human being, stigma is the number one reason why we have this problem, hands down. Because if it's still a moral failing, I'm not going to go get help because I'm not the problem. And you're going to tell me that I am the problem, and why would I go to you? And this gets people to a place where they're talking with somebody who treats them like a human being and then encourages them to get to that treatment and recovery.
Any other commissioner? Go ahead.
This is the same question to start that I had earlier. Can this information be made available to the public, or
Yeah.
is it already?
Absolutely. No, it is not, other than what you guys have been uploaded, but we can,
I'm sorry?
It is now, it's on board docs.
Oh, okay, yeah.
sure.
It's just Google. I read 8 articles last night on it
Okay.
on Google.
We do have, Darius, we do have a couple people who sit, they're doctors that sit on the Jackson Harm Reduction team who have been doing presentations in the community about harm reduction in the opioid crisis specifically. They're planning another one. I don't have the date for it, but I can get that to you too.
Okay, thank you.
Yep.
Also, is there any research or have other cities put out their information as to how they pay for such programs?
Yes.
The cost of treating one hepatitis C patient for 6 months, okay, just one, would pay for a needle exchange program for a year.
So we can have the private sector to our need. Because I have to decide
Yeah.
what I want to distribute where the hospital insurance is paying for that.
And that's where I was leading to. Yeah.
That's the issue. It's not the value. Definitely there. No question about it. But do you and I have to make a decision? Or do we have a needle exchange program?
They can lead and who's paying for it?
Who's paying?
Has,
Yeah, I realize that there's money savings involved. No question about it. Truly saves money, it saves lives.
The Red Project out of Grand Rapids, all of their funding is privately donated, and they do grants. I know at the federal level, I know at the state level, you can't purchase needles with a grant, but you can purchase cotton, you can purchase tourniquets, that kind of stuff. But we've already had interest in the community from some pharmacies that would donate. So I don't know if it would be a huge burden for you.
The other
I
thing,
don't know if I'm sorry.
Go ahead.
I don't know if you can answer this, but has you're representing the hospital, is that right?
No. Drug-free Jackson.
Doug Free Jackson.
Yeah.
Okay, never mind.
Yeah, that's a good question.
the other thing that you mentioned is, in all those reports on the internet that I read, it was the way that you did it, the warm and fuzzy, okay, versus labeling you as a drug addict and so on and so forth. That was a very important part of making the drug treatment programs work with the needle exchange. Very, very important. So in summary, we got two problems. We got hepatitis C and we got HIV. We know that the needles, give it to other
transfer,
people,
yep.
okay, and so on, okay? You want to control the problem. So if you want to control the problem, you got to control the needles, okay? The person comes in, you can control the needles, you gradually wean them off and put them on the valvular, I forgot what that was.
Vivitrol, yeah.
Vivitrol, okay, and so on, which gets rid of the
cravings,
craving
yep.
for it, okay, and so on. And then you can wean them off of that, okay, and hopefully they'll stay drug-free, okay, and so on. But there's another place I read that it takes a couple of times to do that for the person to truly become drug-free.
It does. So the average, it's the same with smokers. It takes a smoker 7 times to stop smoking, on average. And for drug addiction, if I can give you an analogy, we had Dr. Corey Waller, who is a big national drug addiction professional. And his analogy, when they did a study with people at it was Illinois University in Chicago, University of Illinois in Chicago, and they took people, their participants, and they didn't give them water for 3 days, and they measured where their brain was at whenever they would run water in the room or show them water in a cup, and it was relative to the size of a baseball in their brain, their brain pathways of yeah, that's a necessity and I need that. They did it with food for 2 weeks. They fasted for 2 weeks, which is not safe, but they signed the waiver. And then they just wafted food, the smells of food, and they brought it in, put it under their nose, and that was relative to the size of a basketball. So water, for 3 days is a baseball or a softball, and then a basketball for food. When they did it with people with substance use disorder, and they talked about their drug of addiction, and they had them describe how it made them feel. After 3 months, it was the size of a baseball field. After a year, it was still the size of a baseball field, relative to the other two. You have to have food and water to live. So it takes, it's rewiring your brain to say that I don't actually need this to survive, but for a lot of them, when they first start off and even a year in, they need it to survive. It's a very lengthy process. Yeah, yep.
Steve, what was the question that you had before? You talked to me about the needles, about somehow checking the needles for something.
Oh, the question has been asked of me.
Or an illegal.
I have just a dirty needle.
Yeah, that's a good question. We've been trying to figure out how we can do that if we order special needles, because most of them have an orange cap at the end. On almost all the ones that I've looked at from suppliers have an orange cap. So is there a way to get that separately? When we talked with our partners at the Red Project, they don't. And they just made an agreement with the city of Grand Rapids that they're not even going to look for needles. In my perspective, a drug dealer is not going to give their client a needle anyways. They're just going to give them the drug and take the money. And if it is a dirty needle, maybe we consider expanding the Good Samaritan law.
Well, see,
That's a hard
that's the other
question.
side of this. Now with the Good Samaritan law, the dealer can inject
Sure.
the user,
Call the number.
stand there and see if they have a bad incident.
At that time. At that time. They still can prosecute them for other crimes, but, yeah, it's a really touchy subject, and I know law enforcement, like, we've talked with them a little bit of how do we manage this, and I don't have an answer. Grand Rapids, they just don't prosecute for having a needle.
Can we call up those successful programs that I listed and so on and just ask them what they do with their needles?
Absolutely. That would be amazing. And I know, like, in Scott County, because it was a health crisis, they just did it. They just wrote it into their ordinance that anybody with a needle they're fine.
Any other questions for Sarah? Tony?
If the county ends up giving out needles and a drug user uses that needle to inject their drugs and they die of an overdose, I think the county's going to be liable as an accomplice in that death. We facilitated the death of that person by giving the needle that they used. So you're going to have a
How do you not do
heck of a
that?
time convincing me to support that program.
Sure.
The drug supply, I think, is where you'd have the most effect. I went to the Jackson County Drug Summit back in November, and the guy from JNet said the majority of the drugs that we're getting now into Michigan are coming from Mexico. The local labs can't produce it cheaply enough. They can't
Yeah, the
sell it
math,
cheaply
yeah.
enough.
Yep.
They can't compete with the mass volume of production in Mexico. So if you want to reduce the drug supply, support Donald Trump's efforts to build a wall and close the border.
I do know a lot of those drugs are mailed, so that's not gonna, a wall's not gonna help that, but,
Oh, yes, it will.
yeah, I don't know, because you have to consider the supply and the demand, and if we can reduce the demand by getting people into treatment and recovery, there's not gonna be a need for supply.
Tony? I really don't see any difference between the needle program that they're talking about and the condom program that they were talking about for sexually transmitted diseases. You're doing the same thing, only one with a condom, one with a needle. Darius?
I guess kind of jumping back a little bit to, I guess, the finance of it, and that's kind of where I'm kind of stuck as
Sure.
well. I'll just go out and say it. Is the next presentation, will it be to ask Jackson County to,
To fund it?
yeah,
At this time, no, because we have enough, I think we could probably pull enough private funders to figure out, we've had a lot of people who have been like, yep, let me know when this happens and I'll write a check for you. At the same time, we can get grants for a lot of it. So we have a prepaid inpatient health plan that handles it's like Medicaid dollars, that I'm funded through, and they've expressed strong interest in it, in funding that, and so we might be able to get the money from that. I mean, we applied for it, but we had to pull out because we didn't have city council backing on it yet, but I don't, I mean, we might eventually, but I don't think in the short term. Right now, we just want to hand out needles too, so
have we,
it's pretty cheap.
just a continuing question, I have, or have we, excuse me, ran any numbers to see approximately what it would cost at all per year?
Total, so, not yet, and because we're waiting, so, yeah,
Quantify?
we had presented to city council and doing it in the city, and we were waiting on them to even move forward with a lot of things. We've got a lot of things that we can move forward with, this is definitely one of them, but if it gets shut down, then there's no point, but I'm not sure what the RED project, like what their budget is.
Here's what I found on the web for what is the cost for treating hepatitis C.
Grand Rapids.
So,
I mean, it's like 10 cents for a needle, so it can't be.
okay, so it wouldn't be, millions and millions of dollars a year?
No, I would imagine 50,000 or less.
Okay.
If we hired somebody maybe to do like to organize volunteers or to manage it wouldn't be a huge job.
Okay, so I guess my next question would be, and I have one more comment afterwards, I guess would be more catered towards the chair. In the event that the city of Jackson says no, then what would the county's response be at that point?
That's a great
Or is
question.
that just for conversation later? Or?
I think that's for conversation later.
Okay. And so my final comment is that, I've been kind of wrestling with this for a little while now,
Sure.
because I can see it from both perspectives, and so I'm really trying to narrow that down. Your presentation today certainly has helped and to find an answer, but my I guess closing comments would be is that if we continue to move forward with this, I think we need to look at also just the overall drug problem and how do we stop that.
Absolutely.
And so, and I know that's conversations. I mean, we've spoke on this before,
Sure.
so I know this is conversations that you've had before, and I'm sure you have seen. Maybe what other cities are doing, and so I know where your heart is, but I just don't want us just to stop with this project once we have this completed and then become complacent. So although we're taking care of we're trying to solve the health benefits of it in terms of spreading diseases and such, but we're not taking care of the cause of the problem being the drug. So I just
Absolutely.
wanted to continue to encourage you and to challenge you to keep moving forward. Again, we've talked on this, I think maybe it was even last year, or maybe even further
think it was,
back
yeah.
on this subject. So I commend you for your work that you've done thus far, but just keep that energy going. I certainly believe that there will become a day where we can say, hey, we didn't completely get rid of the problems on both sides, but we have significantly lowered the numbers. So I'm hopeful and faithful that we can get there. And again, thank you for your presentation today, and thank you for the work that you've done this far.
Thank you.
Any other questions? Thank you, Sarah and Allison. Your two names are my second and third daughter's names.
I get called Allison a lot. Thank you.
Next time, if you want, talk with me about this.
Okay.
And I think we could work something out.
Awesome. Thank you.
Okay, next on the agenda is the claims. Oh, Health Department, excuse me. Sorry.
No problem. So my monthly report is in your packet, and I want to touch on a few things that it contains and just give you some updates. You'll notice at the top of the first page, I talked a little bit about the active shooter drill that we had at the Human Services Building. It went very well on January 16th. We had 100 Human Services Building employees in attendance. We did basically need to shut the building down as far as services is concerned for the afternoon, but I think it was a very important thing for us to do. The Human Services Building does have a coordinating committee, which the Health Department leads, which meets when needed, if you will, and we're collecting information from all the employees who participated in it, ask them to share their ideas and opportunities for increasing safety and security, et cetera, and we'll be meeting sometime this month, hopefully, to review those. I had mentioned the new program to screen pregnant women for lead exposure. I did an update there. I had indicated that the latest education and training resource to be released was attached. I missed attaching it, so if you were looking for it in board docs, you would not find it. But no, I don't think it's a big deal. It just was communicating what had been sent out to the users of Epic, and it was primarily a screenshot of how to navigate through the electronic medical record to make the referral. Under Health Officer Recruitment Update number 5, a little update there. We did review we reviewed all of the 44 applications that have been received thus far for the health officer position, and we've narrowed down at least to just 10, and it'll probably be narrowed further than that as we hopefully get together in a meeting on Friday with the key members of the interview team. So I just wanted to let you know where that's at. Other items, over on the second page, we received a $3,200 mini grant for assistive technology that we could utilize at points of dispensing sites, if you will, that the health department would operate in the event of a public health emergency. It's called Whole Community Inclusion Planning is what this falls under. And we did receive the $3,200 mini grant that we applied for, and our emergency preparedness coordinator is currently obtaining what you see listed there that would be available at a pod site should we have someone that we could help with that particular function and access technology. In your inboard docs also is an Access to Care Coalition document, the Insurance Gap Work Group Report on Jackson County's uninsured. This could be, if desired, a future presentation to this committee if you wanted to do that. But the bottom line is that we are able to identify that there are some significant disparities in health insurance status in the community, in many places in Jackson County, and it affects different genders, age, and race ethnicity groups. So if you have questions about any of that executive summary, I'm happy to answer questions about it. But it will be a focus as an objective of the Access to Care Coalition moving forward in 2019. Teen Pregnancy Prevention Initiative, we shared data with Commissioner Mahoney at his request. That is an attachment as well in board docs, and can answer any questions you might have about that. But certainly disparities in rates by race and within the city versus the county are clear for teen pregnancy, which is underscoring the reason why we have historically and continue to focus on at-risk youth in schools, particularly within the city of Jackson, as the focus for our efforts in teen pregnancy prevention. Hepatitis A outreach vaccination funding, we received notification that $5,000 allocation was again available. However, they also offered us an additional $20,000. And I can happily report to you that our application for the full $25,000 was awarded, and we will be increasing the frequency of our visits to Jackson County jails and the Interfaith Shelter Drop-In Center and other locations in the community that have been successful vaccination sites. We still do not have a outbreak associated case of hepatitis A in Jackson County, but anything we can do to increase hepatitis A vaccination levels will prevent transmission, period. So we're happy to do that. Under environmental health, primary content there is an update concerning the former Missioner Plating Plant on Mechanic Street regarding PFOA and PFOS. These are the polyalkyl fluoroalkyl substances, if you will, long-chain hydrocarbon chemical compounds that were used for years in the plating industry as a water repellent and lots of other different kinds of products. Widespread use in general for lots of different products in the nation. So we met with representatives from the Remediation and Redevelopment Division of DEQ, and we had people there from the Health Department as well on January 4th. And the next steps, if you will, concerning the contamination problem at the Mitchell plant are laid out there. The Water Resources Division was doing additional sampling of the Grand River, groundwater and water accumulated in the basement on site. They're looking at conducting some vapor intrusion investigation work as well at 9 off-site properties, and the primary reason for that is because the plant also used a lot of volatile organic solvents and compounds that if we have PFOS and PFOA all over the plant, in the basement, and in the groundwater, we probably have other things to be concerned about as well. Well, I just got some sample results yesterday that Don Haydick, our EH director, shared with us. There is contamination upstream of the plant in the Grand River. It is not at a level that exceeds a standard for surface water, but they did find additional contamination in the groundwater monitoring wells and in the basement of the building. Now, there are only health standards for 2 of the perhaps dozen compounds we're talking about here. So PFOA and PFOS has a health standard of 70 parts per trillion total. None of the samples exceeded that from a health standard perspective. But the overall level of PFOS, if you will, in both the Grand River sample sites as well as the groundwater and the basement of the building are up in the four-digit thousands. So we're talking 2 to probably 4,000 total parts per trillion of PFAS. But
What's the bad level?
the bad level right now that's established is for 2 of the compounds is 70 parts per trillion. And we didn't, and we're in the thousands overall, but not for those 2 in the sample size that were tested. So we're kind of somewhat in the clear at this point in time, but obviously PFAS levels that are in the 1,000 parts per trillion is still a big concern and a problem. So some of the action points and outcomes that,
Processing that.
Okay.
I understand.
yeah.
You said we are overall good.
We're okay with respect, we're okay with respect to the 2 compounds for which health levels of concern have been established. We have another 10 analytes for which no standards have been set. So it's difficult to say exactly how health hazardous they are.
So PFAS.
Overall, yep. The overall level is between 2 and 4,000. But it's specific to those compounds. Compounds,
Oh, you're adding all of that.
yeah,
Okay.
yeah. It's, well, believe me, it was confusing for us too.
Have been tested to be a no carcinogen or a possible carcinogen?
No, PFAS and certain key analytes within the overall PFAS compound family have been found, yes, to be cancer causing. Yes. And it's a work in progress. I'm sorry, I can't be more specific, but
You said you found it upriver from the plant?
yes.
That means it could be in a different facility.
Uh,
Deposited from a different.
Well, when we say upstream, we mean that the direction that the water is flowing away from the plant is where we found it.
You found it.
Yes,
Okay.
north of the
Could
plant.
be coming out of.
So it's likely coming out of the plant, right?
Well, there were other south of the Mitchell plating site,
Okay,
you know.
yeah. Were they in close proximity to the river? Do you know?
Yeah, I can think of a radiator.
So maybe we should be testing for ethylene glycol?
My experience with you and the EPA has been if you test it.
Well, given our industrial history, you're probably absolutely correct. If you test for something, you're probably going to find it.
That's correct. Burned bad coal in Jackson.
So we have plenty of lead and mercury contamination.
And arsenic.
Yeah.
And all the other good stuff.
I can't find any good coal.
Yeah, the stuff from Pennsylvania is 98.6% pure.
So that's everything I have for you today. I'm happy to answer any questions.
More just to put it on your radar, thank you for all the information also. Your reports are always very detailed and always leave us with a little bit of concern. So I don't know if this is your wheelhouse or not. Definitely let me know if you like, hey, yeah, thank goodness we don't got to deal with that. But I've had a couple constituents recently bring up some concerns with the overpopulation of bed bugs. And I don't know how bad it is within the county as a whole, but I know within the city, it's a very big problem in different departments because they travel on people. So there was just some concern, and a few people said, hey, we wonder what the health department has to say about this and what they may be able to do with curbing this in the city, or if that's even something that would be on your radar.
Well, it's absolutely on our radar because we do get complaints about it as well from the public. And either fortunately or unfortunately, depending on how you want to look at it, The health department doesn't have any direct responsibility for treating the problem, if you will. It isn't an insect that is known at this point in time or capable of transmitting diseases of concern. It's more of a nuisance bug, and obviously people who've been affected by it and have been bitten by them would probably say it's more than that, and I get that. The primary approach here in the community thus far has been to work particularly with facilities in the city, whether they be institutional or landlord-operated locations, is that it's their responsibility to address the problem. Primarily, that's where it lives. We have plenty of information on it, though, at the health department if you need something. Okay. You're welcome.
Next, I believe, is the claims. All in favor? Opposed? Motion passed. Any other minutes? I think that we're adjourned. Pardon me? Oh, public comment, excuse me. Anybody want to say anything in public? Okay. I entertain a motion that we're adjourned. Any what?
Committee meeting comments? Committee member comments?
Nothing I know of. Public comments.
Usually
Oh.
on the other
Okay.
side, number 7, comments.
Okay, any committee member comments? Getting good at this. Any other committee member comments? In which case, we've already got our motion to adjourn. It was seconded. All say aye. We're adjourned.